Welcome to the Department of Medicine Cornell's. Yesterday, I had the pleasure of visiting NYU, and they gave me a tour of Bellevue Hospital, which you may know was started in the 1700s, perhaps one of the oldest, if not the oldest, continuously growing hospitals in the United States, which has a rich history in many areas, but particularly in the area of tuberculosis. And I was able to tour the place and see the wards for tuberculosis that they've had there for years. They have a Yale in the same hospital. They have all these, they are the main place where you take care of multi-resistant tuberculosis as well. So they're very well trained in that area. And I was able also to see and actually touch the instrument used in the early 1900s for developing pneumothoraces for these patients. Before these anti-tuberculous drugs came about, they would inject air into the chest wall and collapse the lung, and without air and expanded lung, the tuberculosis bacilli was expected to die. So that was interesting. It was even more interesting when I found out when I came back that on this day, December 11th of 1843, was the birth of Robert Koch. And Robert Koch was the founder of the science of bacteriology. He discovered the tuberculosis bacilli in 1882, cholera bacilli in 1883, and he's named as the founder of the science of bacteriology. He also studied bubonic plague, and he won the Nobel Prize for his work in tuberculosis or physiology of medicine in 1905. On this day, on 1911, Marie Curie becomes the first person to win a second Nobel Prize. Not one, but her second. The first one she won with Pierre Curie, her husband, in physics. The second one for her efforts in chemistry. In 1957, scientists discovered the antiviral properties of interferon, and it was called interferon because it interfered with viral replication, and I think our speaker will tell us a little bit more about that. And then in 1998, on this day, 1998, Science published a paper by scientists who deciphered the entire genetic code of C. elegans. And the nematode contains about 20,000 genes. It has a digestive system, it has a nervous system, sexual organs, and all that. And it was considered a milestone to understand later on the genetic code of humans. On that very year, the FDA approves Revitron for the treatment of hepatitis C. And with that, I'll leave you with Dr. Craig McLean, who's going to introduce our speaker of the day.
Last week, Dr. Roman talked about the importance of training our own and getting residents and fellows that are sitting down there to become faculty talking up here. And our speaker today actually epitomizes that. Matt Cave is a native of Louisville. He was a fellow here. Actually, we've had several parties on his parents' farm, had a great time. And Matt has done all the right things. So he decided when he was a fellow that he was going into academic medicine. He picked a mentor. He started doing research. He then got an AASLD award to help support his academic career. Next, he got a K-23 award, which he actually still has. After only a year or two of his K-23 award, he got an R01. He then has several NIH subcontracts, and he actually writes the definitive textbook chapter in his area of research expertise, which is environmental liver disease. Matt's not going to talk about that today. He's going to talk about hepatitis C, and actually he's not going to talk about either of the drugs I think that Jesse mentioned. Those are for old guys like me. So hepatitis C was actually diagnosed in the late 1980s, a little after HIV. And I can remember Dr. Marsano and I first treating people with interferon and getting a 5% cure rate, torturing these guys for 6 months to a year, and thinking that we were doing a fantastic thing because nobody had cured anybody with HIV. That's all changed, and Matt's going to tell us about that today. Matt.
Thanks, Craig. thank you all for coming this morning. I've got 53 slides, so I'm going to keep moving, get through them, which was actually good. So Luis Marzano's got 380-something slides in his Hep C deck. This is a brand new deck. So Hep C is changing so fast. I gave a Hep C update a year ago. Then last summer I gave one to this past summer to Rosemary's renal group. I couldn't use one single slide from the 6 months previous, and now I think I've used maybe 5 slides from the deck I gave to nephrology back in June. I mean, this is how fast things are changing. Okay, disclosures. All right, so case presentation. I'm going to do things a little bit differently. I've got 2 cases. So the first case is a 55-year-old African-American male healthcare worker. He's referred for Hep C, which was a new diagnosis detected through age-based screening, which I'll cover. He's really scared and he wants treatment because his dad died of liver cancer, which is not an uncommon thing, unfortunately, in our patients. But he said, well, dad was an alcoholic, but I'm still scared about this. And you'll see in the CDC poster, this is a campaign that they're doing for Hep C awareness. And it says, don't say I'm all good just because I don't have symptoms. That's this patient. He didn't have any symptoms. But down in the fine print, Hep C can lead to liver cancer. And, so in my experience, patients oftentimes don't care that they have Hep C. They don't care that they might get cirrhosis. But God forbid they'll get liver cancer. And so that tends to motivate a lot of patients. So we worked him up in labs, liver biopsy, confirmed the diagnosis. The guy had been watching TV, reading the internet, heard about the new medicines for Hep C. He requested one. I prescribed it because he learned that there's a cure. Many patients don't know that there's a cure now, but he learned this. And so, unfortunately, his pre-authorization was denied, however, by his insurance company. And they said, well, we only cover this medicine if you had cirrhosis. So the guy's obviously pissed. I paid $5,000 a year, and they're abandoning me. I've never used them before. And he's scared that he might get liver cancer. Says he's going to sue his insurance company. And then he tells me a very insightful thing. He said, well, this is like not covering insulin until you go on dialysis, or not covering your antihypertensives until you've had your MI. So very upset patient. I'm going to tell you about the flip side here. Now this is the story of insurance company CEO, and I've met with many insurance companies about this issue of hepatitis C. So this is actually a true story. So insurance company, they cover 11 million members that are insured. They reckon there's 250,000 people that they cover that have hepatitis C, although only 14,000 have been identified. Now the wholesale acquisition price of one of the new Hep C medicines is $94,000. And so they're having trouble on Wall Street. Their stock is sliding because they're failing to meet earnings estimates. And the reason that they're doing so is the cost of the hepatitis C medicines. And just doing the math, it'll cost more than $20 billion to cure all 250,000 members with Hep C. And that's more than their market cap. Their market cap's about 21. It's going to cost about 24, 25 billion. And so obviously they can't treat everybody. And so who are you going to cover? Then when you get a script for a pre-auth. And some things that I've heard from the businessmen in the insurance company is, well, our members turn over every 2 years. We've only got them for 2 years. So why are we going to pay $100,000 and they'll leave us for someone else? Whoever they go to will get the benefit. We'll never see a return on our investment. All we're doing is saving Medicare money because these guys aren't going to get their decompensated cirrhosis till they're 65 anyway. So why do we care? And they'll just get reinfected, go out and use drugs and get Hep C again anyway, or just keep on drinking and get cirrhosis. So, I think both sides have very reasonable concerns here. I'm always going to be on the side of my patients, but I think I can understand views of all parties. All right, so lessons learned. Hep C is curable, and we've gone from discovery to cure in only 25 years. So this is fantastic. Hep C patients are anxious about their potentially life-threatening disease, and they come to see us at UofL to get cured. And the last one is probably the most important issue we're facing. So the high prevalence of Hep C combined with the high cost of medicine make this the largest single financial impact to the healthcare system in the history of the world, period. So this is bigger than cancer, not colon cancer, not lung cancer, all cancer combined. This is bigger than cardiovascular disease, not heart attack, not stroke, heart attack plus stroke combined. So this is a lot of money at stake here. All right, so objectives. I'm going to talk about Hep C natural history and epidemiology, new hepatitis C treatments, and some of the innovative solutions that we're a part of at UofL. Put things in perspective, there are more Americans with Hep C than breast cancer, prostate cancer, and HIV, and there's nearly as many as there are with congestive heart failure. And actually, there's probably more with Hep C than heart failure because these statistics are based on NHANES numbers, and NHANES excludes veterans, prisoners, institutionalized for mental health, and these are the highest risk groups for hepatitis C. So the 3.2 million only if you count the low-risk people. So I think most people believe it's somewhere between 5 and 10 million. All right, so this is what Dr. McLean was talking about back when he was young. He was all the way on the right side of the graph. And it looks like he was doing better, or he was doing worse than other people were. He was at 5%. Others got all the way up to 6%. But then coming over time, we're now up to 99, approaching 100% cure rate for hepatitis C. And today we don't have to use interferon. Many times we don't even have to use ribavirin. And it can be as simple as 1 pill a day for 8 weeks to get up close to 100% cure rate. So why is hepatitis C curable? You can't cure anyone's HIV, you can't cure anyone's hepatitis B, so many chronic viral illnesses are not curable. What's different about Hep C? So Hep C is different because it's an RNA virus. It does not integrate into the DNA, and so there's no reservoir for the virus. It has an extremely high replication rate, so if you have Hep C, your liver is basically just a factory for virus, and it makes 10 to the 13th viral particles every single day. But you clear 10 to the 13th viral particles every day because it's at a steady state. And Hep C is dependent on this high replication rate. And fortunately, there's several proteins that are involved in its replication to achieve that high rate. And these are all good drug targets. And we have drugs against many of them now. And so we combine them in a cocktail similar to what one might do for HIV. Okay, so natural history of hepatitis C. So people get acute infections, and I'll talk a little bit more about that on the next slide. Some of them will actually cure the virus, and it's probably higher than this. These numbers, I think, were devised by studying injectors that were on the street, homeless, and not taking care of themselves. I think this is probably higher people that aren't on Skid Row, so to speak. But at any rate, most people go on to develop a chronic infection. And now what we have to be cognizant of here is that there's extrahepatic manifestations of Hep C. This is not just a liver disease. Some patients will go on to progress to cirrhosis over a long time, about 20 years. Some will develop liver cancer, and some will go on to develop decompensated cirrhosis, which has a miserable 5-year survival rate. Okay, so what about the effects on the liver from Hep C? So Hep C is the leading cause of cirrhosis, the leading cause of liver cancer, and the leading cause of liver transplant in the United States. And liver cancer has just become our scourge. So I just got off service at UofL. We had 4 to 5 inpatients a day actively dying of hepatocellular carcinoma. And I think we had a death about 2 nights ago from HCC. So this is the most rapidly growing cancer, perhaps other than skin, but definitely the most rapidly growing solid organ tumor, and it's being driven by hepatitis C. All right, so what about extrahepatic manifestations? I think the nephrologists know about these more than anything else because hepatitis C causes cryoglobulinemia, which can cause membranoproliferative glomerulonephritis and put you on dialysis. And indeed, approximately 25% of the UofL dialysis population has chronic hepatitis C. It's also effects on muscles, joints, skin, eyes, endocrine system, and also lymphoma. So hepatitis C can cause non-Hodgkin's lymphoma, and we treat a couple patients a year that are referred to from the bone marrow transplant unit after their lymphoma has been cured. And about half of patients may have at least one extrahepatic manifestation of hep C. So just keep in mind this is a systemic disease, and this will become important in a minute when I talk about all-cause mortality and survival. So how are we doing on hep C? So as healthcare providers, we're doing awful. So this is, probably the most curable condition in internal medicine. So how many chronic diseases do we actually cure? All I want to do in clinic is treat these patients, because like Craig said, I've got all kinds of NIH research I want to do, and I never want to see these patients again. They can come in, hi, take these pills, you're cured, go away, let me do my NIH research. And you can't do that with GERD, you can't do that with IBD. God knows you can't do it with IBS. They just keep coming back. So this is a curable disease, but we're not doing very well. So there's low number, again, 3.2 million that have hep C. Less than half, this is too high, less than half of them know that they have it. Once people know they have it, most of them aren't even referred to care, which kind of blows my mind. If you're primary care, you diagnose this, and then you don't send them out to treatment. But this is what's going on in the U.S. And then once they land in specialty care, even fewer of them get treated. And this is presumably due to interferon contraindications in the past. Now it's due to insurance denials. And then you look down to successfully treated, 5 or 6%. After when you talk about a disease that's 100% curable, and you're only curing 6% of them. And so we're doing poorly. There's opportunity for improvement. Now this is probably the most important slide in the deck, and this is why I even in people with minimal liver disease and no extrahepatic manifestations, this is why I still advocate to treat them. And that's because achieving sustained viral response, which is the same as cure, it reduces 10-year all-cause mortality by 17%. And so this study was done in patients with halfway to cirrhosis or higher. So they had advanced liver disease. There was a study at AASLD, a poster that looked at more patients with hep C that didn't necessarily have advanced fibrosis. And the reduction in all-cause mortality was less, but it was still very high. And to put this in perspective, if you take someone 65 years old with advanced coronary artery disease and give them a statin, you reduce mortality by 12.7% over 10 years. And so we're at 17%. So I'd venture to guess that you wouldn't be working here very long if you didn't put people that had MIs on statins. But for some reason, not diagnosing hep C and not curing hep C is acceptable, even though it leads to a 50% better survival than a statin does. Just to put things in perspective. So 26% mortality in patients that don't get cured versus 9% that do. And these numbers were gathered from people that were in clinical trials, so they were the same population. It was just looking at those that didn't get cured versus those that did. So there's 6 genotypes for hep C. Each genotype has its own specific treatment. In the United States, we have primarily genotypes 1, 2, and 3. That's what we have in Louisville. This is important because every genotype has its own treatment. All right, compared to other infectious diseases, since about 2006, 2007, the annual age-adjusted mortality rate is higher for hepatitis C than HIV. And in fact, the number 1 cause of death in patients with HIV is hepatitis C. Correct me if I'm wrong, Julio, but I think it still is. It's at least liver disease, and among their liver disease, I just saw someone in clinic that was co-infected yesterday with hepatitis C, HIV co-infection. So it's very important to treat these patients because they're just as curable as anyone else today. All right, so hepatitis C, decompensation, and liver cancer are expected to continue to rise in the United States. So here's decompensated cirrhosis. We're right here at about 100,000 cases. which we're inundated with, but we're going to see 50% more by 2020. And along with this rise, you see this increase in hepatocellular carcinoma. And nobody takes care of hepatocellular carcinoma like we do, and Dr. Ashutosh Barve in his clinic, and Marvin and our surgeons. So, we get basically all of these in Kentucky, or at least some will go to UK, but we're seeing all of these patients. More mortality statistics. So most Hep C related deaths come in people aged 45 to 65. The median age was 57. This is 20 years less than the average US lifespan. All right, so most people with hepatitis C were born between 1945 and 1965. This is a so-called baby boomer cohort. And many of them have had this disease for a long time, and so they've progressed to advanced fibrosis. About 1/3 of them had stage 3 to stage 4 fibrosis, stage 4 being cirrhosis. Most of them don't have any other identifiable risk factor for how they acquired the virus. They say they've never used drugs, never had a blood transfusion, never had a tattoo, never had unsafe sex, but yet they have it. And so being born between 45 and 65 is an independent risk factor for having Hep C. It's just as strong of a risk factor as being a drug user. And so we need to screen for that. And so what about the cost of screening? So I told you how much these medicines cost, but it's still cost effective to screen and treat because the treatment is 100% curative, or nearly 100% curative. And so compared to other things that we do in primary care, depending on which treatment regimen you use, Hep C testing and treating is $15,000 to $35,000 cost per quality adjusted life year. It's actually better than cholesterol, better than breast cancer, and it's on par with flu shot or hypertension. So again, I don't think Jesse would keep you around if you didn't believe in flu shots, didn't measure people's blood pressure, didn't treat cholesterol, hypertension, or God forbid, if you didn't do mammograms, you'd be on the nightly news. So these things are totally unacceptable, but yet nobody cares about hepatitis C, which is as good or better. And so because of these data and others, the CDC cares, and the U.S. Preventative Services Task Force care, and so they've recommended screening for hepatitis C in those with risk factors for blood exposure, as well as the so-called baby boomer population. This is covered by the Affordable Care Act. So what do you do in primary care? You get a one-time antibody test. If it's positive, do an RNA, viral load, and refer. If it's negative, you're done. Now, things are changing. So most Hep C is in the baby boomers, but things are changing right here in Kentucky. And Kentucky is one of the worst 4 states in the country for hepatitis C, maybe the worst. And the reason I say that is recently there was a health clinic-based screening in northern Kentucky counties of Boone, Campbell, Grant, and Kenton, 2012 to 2014, and there was a 15% prevalence of Hep C in these health departments, 15%. So national average is 3 or 4%. This is 15%. And the scary thing is, and this just frightens me to death, is that the ages you're seeing this in are now in 20 to 30-year-olds. That's who's testing positive. And we see this every day in our practice. So we have an epidemic of young Kentuckians acquiring hepatitis C. I'm going to tell you a little bit more about why. But here's just further evidence that we're in the middle of this outbreak. So these are Hep C incidents in the U.S. in 2006. The blue's worse. And look how much worse we've gotten in Kentucky. So, we're the Appalachians, the worst in the U.S., and northern Kentucky is now probably even worse than they are. These are acute Hep C cases. So when I was a resident and a fellow, I'd never seen acute hepatitis C. Now, when I'm on call or on service, I see at least 1 or 2 in the hospital every single time. And so I don't know how many Hep Cs actually get hospitalized, acute Hep Cs. I'm guessing it's 1 in 100, 1 in 1,000, maybe less than that. So the fact that we're even seeing any, this means we're just seeing the tip of the iceberg. And who's getting acute Hep C? Again, it's 20 to 29-year-olds are the people that are getting this. And why are they getting it? They're getting it because they're young, because they use prescription opiates, because they share equipment, and they're men. Now, opiates are critically important because you don't get Hep C from cocaine anymore, and you don't get it from meth. Well, very rarely you can, but in general, you only get it from opiates, which is a curious fact, and I'll tell you a little bit more about why that is. So here's some more proof showing that Hep C is associated with opiate use. So these are Hep C cases, the red's the worst. We're in a red state, and the red states are same as the green states, basically, and the green states are the ones that prescribe the most opiates. You can see that the two are linked. We're dark green, so that's 8.5 to 12.6 kilograms of opiates per 10,000 people. Kilograms of opiates per 10,000 people, so this is just crazy. Heroin use is also on the rise. And what kind of drugs are we using here in Kentucky, and who's using them? So here's opiates going up, other drugs staying flat. Age 12 to 29 going way up, other ages going up but not as fast. What are other demographic factors associated with opiates and heroin? So this is a disease of white people. We've got a lot of white people in Kentucky. Used to be non-whites, now non-whites are going down, whites are going up. And this is a disease of economic despair. And so it's thought that since Kentucky has one of the highest youth unemployment rates in the United States, that's where our young adults are getting Hep C. They're unemployed, they have despair, and they're using opiates and heroin. This is a scary slide. This, to me, may be the scariest in the deck, actually. So hepatitis C can live up to 63 days in a syringe in the dead space. It can live 21 days in a water bottle. It can live up to 14 days on a cooker. So you put Hep C in a spoon, melt your tar heroin, that Hep C is still alive for up to 14 days in there. And this kind of thing scares me to death because I don't know how many times I've been vomited on with variceal bleeding. And the Hep C is still alive in my clothes somewhere, I don't know. So young people get Hep C, and the reason they get it is because they're called neophyte injectors. So young people share in social media. They're used to sharing things with each other. They like to party and have fun with their friends. They share with their peers. They have risky injection practices, and they have less injection competency, which I'm not an addiction person, but I find that as an interesting term. They're incompetent injectors. That means they can't find their veins very good, and they don't know about the danger. It's probably because they were born after HIV after it stopped being a serious disease, and so they weren't alive in the 80s to be scared of AIDS, and they don't really even care. I see them all the time. Unfortunately, they're just getting Hep C and not HIV. And I used to tell them that. I used to try to scare them. Well, you're lucky you just got Hep C. We can cure this. What if you got HIV? Well, I don't care. Magic Johnson's had HIV longer than I've been alive, so I'm not scared of that. So you can't scare these kids. And this is important too, abuse-deterrent tablet formulations. I'll show you a picture of this in a minute. So these are incompetent injectors, I guess. So they're missing their vein. They're young people. They're not skilled in this. They wipe up the blood and this little gauze here. They put their gauze and their bloody finger in this heater, which they pass around, and then they're using the same water bottle. And so they're just passing it around to each other. The older, more skilled injectors don't do that. Now, this Hep C in young people is a total conspiracy. So everybody loves conspiracy theories. So we're seeing this the most in the nation, and partially due to Casper. So Hep C in young people is perhaps related to Casper because of this increase in heroin that we've seen. But it started further back, and it's related to the methods of injection. And the second conspiracy, and it's drug companies' fault. So when people started using oxycodone and then Opana in order to deter abuse, the manufacturers put a material in there to absorb water. So these pills are not absorbable, so you can't put them in water and dissolve them and then inject them. So they put cellulose in them, which is what you use in a diaper, right? But everybody's had kids know, at least if you were ever a house staff and on call and came home to a dirty diaper and not delaying the change as long as you can, they will pee through the diaper eventually. And so just like that, if you put enough water in your OxyContin, you can still dissolve the OxyContin and inject it. And so how much does it take? It takes 3 cc's. You can Google this and get directions on it. And so needle exchange programs don't work, not only because of the cooking surfaces that are contaminated, but also because they distribute diabetic syringes. And these are not 3cc syringes. They won't dissolve in OxyContin. And so people don't use them. The most valuable thing in the world is the 3cc syringe in certain circles. And the problem with the 3cc syringe is the needle that you use on it has a dead space which is 40-fold bigger than the dead space in a diabetic syringe. So by having to use this needle because of manufacturing of OxyContin, you get 40 times more Hep C injected into you every time you use drugs. And you don't have to use this big needle. You can use a little one for meth and for coke, and that's why you get more Hep C with opiates than meth and coke. And so the CDC is now advocating a new kit for every hit. So they'll not only give you the 3cc syringe, they'll give you the spoon, the tourniquet, it looks like maybe a scalpel or something too. I don't know what they're doing with that, but that's what they advocate. All right, so that's some of the bad news about Hep C. What about the good news? We've got multiple classes of medicines, protease inhibitors, NS5A, replication complex inhibitors, polymerase inhibitors. I've circled in red the new drugs from each of these classes. The AbbVie drugs will be approved next week, but I went ahead and circled them. So you can see we've got multiple medicines, multiple classes. You can guess what's coming. Like HIV, we just combine medicines from different classes. But unlike HIV, we cure the disease. So the most recent one that's been approved is ledipasvir-sofosbuvir, fixed-dose combination for Hep C. It's the first and only once daily single tablet regimen for hepatitis C, and it's the first FDA-approved interferon-free and ribavirin-free regimen. So just think about it. One pill once a day, it can be as short as 8 weeks. So who can't do that? I mean, this is easier than treating hypertension, because it's 8 weeks in some cases and you're done. And the reality is, we always check labs because we're obsessive compulsive, but the reality is you can probably just give it to them and tell them to go away, and they're going to be cured. So it's not like even blood pressure. You have to keep bringing them in and checking their blood pressure every time there's not a follow-up. So this is very easy to use, and I'll show you the side effect profile. So it's got a polymerase inhibitor and an NS5A replication complex inhibitor. They were studied in thousands of patients, 3 clinical trials, the ION studies in phase 3 development, 800 patients, 600 patients, 400 patients, so several thousand. These are the biggest Hep C trials ever done. And I'll show you some of the data. Now, in each of these studies, ION 1, 2, and 3, there were 4 groups looking at 2 durations of therapy, and each duration of therapy was with or without ribavirin. And you can see in each of the arms, and there's different patient populations in each of these groups, but you'll see high 90s all the way across the board, very tight error bars. And so there was a 97% overall cure rate. And it's important to keep in mind that these are intention to treat analysis. So half of the failures were lost to follow-up. And as they're beginning to find these failures, they were cured, the failures. And so it's probably 98, 99% cure rate in reality. What about the side effect profile? Fatigue, headache, nausea, and insomnia. I've got 3 of these 5 right now. So we'll be breaking down into subgroups for this regimen. Non-cirrhotics, treatment naives, 96 to 99% with 12 weeks of treatment, 97% with 8 weeks of treatment. Treatment experienced non-cirrhotics, 95% with 12 weeks of treatment. Cirrhotics that haven't been treated, 94% with 12 weeks of treatment. And treatment experienced cirrhotics, 100% with 24 weeks of treatment. So you pay a lot of money, but you get what you're paying for, I guess. Another second interferon-free regimen was approved either last week, week before last, just within the last several weeks. But we've been using it off-label for a while, and that was the combination of cimeprevir plus sofosbuvir, also for genotype 1. And I neglected to say the Harmony regimen, this ledipasvir-sofosbuvir, is only for genotype 1 disease. This is also only for genotype 1, but that's 3/4 of what we see here in Kentucky. And so this is a protease inhibitor, and you pair that with sofosbuvir, which is the polymerase inhibitor. It's 2 pills once a day. You see the molecule fitting very nicely into the binding pocket. What about cure rates for this regimen? And so these are previously treated patients without cirrhosis. So 12 weeks of treatment without cirrhosis, 95% cure rate. And what about cirrhotics? 24 weeks are required, but you get 100% cure rate. N's are lower in this study because it was a phase 2 trial. But we've been using this for about a year now, and we've seen very high cure rates. Side effect profile also very good. Fatigue, headache, nausea, insomnia, pruritus. This particular protease inhibitor has a unique side effect of rash and photosensitivity, which can occur. All right, what about the other genotypes? I've shown you 2 interferon-free regimens for genotype 1. What about 2 and 3? The regimen is sofosbuvir and ribavirin. Non-cirrhotic genotype 2s, high 90s plus cure rates, a little bit lower for cirrhotic genotype 2s, but still, around 90%. There's not that very many. Not going to be very many of these cirrhotic genotype 2s as we're going to cure them all. Now, the area we need help with is genotype 3. So you'll see the low rates with this same regimen, this sofosbuvir plus ribavirin. And it took the company time to figure out how long you have to treat genotype 3. You have to treat it longer. So 12 weeks, 60%, 12, 12, 12, 16, and you get up to 24 weeks, it's 89%. And so the indication is for 24 weeks for genotype 3. And that's still a very good cure rate, but the area that we're let down on is the cirrhotic genotype 3s with a relatively disappointing 67% cure rate, which was over 10 times higher than McLean was getting back in the day. So in perspective, it's still pretty good. So even more regimens are expected soon. So AbbVie is going to get approval next week of their regimen, which was studied in about 3,000 people. It had a 97% overall cure rate for genotype 1 with a good safety profile. These are some data from genotype 1Bs for AbbVie, and their regimen, this was the regimen without ribavirin. Here is with ribavirin, 210 patients roughly in each arm, 99.5% cure rate in this arm, 99% in this arm. There were only 2 failures, and those were lost to follow-up, and they found them and verified that they were cured. So this has a 100% cure rate in genotype 1B with about 210 patients studied. So fantastic. Bristol-Myers Squibb had a new drug application out to FDA for a regimen for Hep C for genotype 1, but it only cured 85% of patients. So they decided this is not competitive anymore. 85% is not good enough. So they took their application back. They withdrew their FDA application, although one of their drugs may still be approved next year for use with genotype 3, which is an unmet need. And Merck has a good regimen too that was just presented at our liver meeting last month with a 96% SVR rate. So we've got many more regimens coming. Hopefully over time with market competition, this will drive down the price and increase access for our patients. Now, what are we doing at UofL to address these problems and take advantage of these new cures and bring them to our patients? Well, we've got several initiatives that are going on that I've been involved in. So right now, we have multiple clinics that treat hepatitis C, HCOC, AIM, Jewish Hospital Transplant Center, the VA. So we're going to treat and cure about 400 patients with these new regimens this year. And this is very, very high. We may be most or second most in the state. I'd like to become the most. But I'm pleased to announce that we're going to open a new dedicated hepatitis C clinic first quarter 2015 with a partnership with Kentucky One. And so the goal is to facilitate linkage and access to care across the entire statewide network. So we figured that there's only about 20 providers that treat any significant number of Hep C in the entire state of Kentucky, and most of them are concentrated in urban areas. And so once you get out in the state, and places where Kentucky One reaches that are not in urban areas, there's nobody treating Hep C. And so our concept is that if we can implement long-term EMR age-based screening and identify the young drug users, we can get them into our network through Kentucky One and then pull them in to treat them. The clinic will be staffed by UOP expert providers, and it will be located initially at Jewish Hospital, and there's opportunities long-term to do some outreach and telemedicine, and now more exciting than that, something called telementoring using a Project Echo model, which I'm not going to talk about, but I'm excited about this. We have support from specialty pharmacy and transplant. We're going to use new technology. We're going to get the second FibroScan in Kentucky. I'm going to tell you what that is in a minute. And we're going to have a dedicated phone line and staff for you to refer patients to. We don't have the number yet, but we're trying to get 844-HEP-CURE as our contact number. I'll let you know if we end up getting that, but that's apparently available. So more information will come when that's available. So FibroScan. So this is Carol Whitledge at our VA. She's one of our nurse practitioners, and she's using what is the first FibroScan machine in the state of Kentucky, the first and only one right now. And so this is cool. So third-party payers now are pretty much just saying what they told the patient in the case presentation. You have to have a certain stage of fibrosis before we'll cover your medicine. And they're all different. Some are cirrhosis, some are stage 2 or higher, some are stage 3 or higher, but they all want to know the stage, unless there's a severe extrahepatic manifestation of Hep C like MPGN. But in which case they still want to know the stage, but they're probably going to approve it anyway. And so fibrosis assessment has become important. The gold standard is liver biopsy, but what if you get a liver biopsy in your stage 2, and your plan only covers stage 3? You're going to come in next year and get another liver biopsy? You're going to get a yearly liver biopsy until you're stage 3? I wouldn't sign up for that, and patients don't want to do that either. And so this is like a portable ultrasound machine in a cart that uses a new science called elastography, which measures liver stiffness, which can be correlated to fibrosis. So Jesse, you'd love this for pulmonary fibrosis. If you just had a little magic wand, you could put on over the lung and push a button and it tells you how bad the fibrosis is. We've got that for liver. And there's only 1,000 worldwide. We're also highly involved with the competing non-invasive technology called magnetic resonance elastography, and we've had the developers of that technology from Mayo Clinic. They came down recently for our NIH-funded liver symposium, which was also Department of Medicine funded, so thank you very much, Jesse, for that. But we've used that conference as a way to increase our ability to, or at least knowledge about elastography. And this MRI is really cool because if you do a liver biopsy, you know the fibrosis in 1/50,000th of the liver. If you do the FibroScan, you get a bigger beam, and so you know the fibrosis in like 1/500th or 1,000th of the liver. And the fibrosis may differ from area to area of the liver. You do the MRI, you get the fibrosis of the entire liver. So neat technologies. And finally, a couple other solutions. So we're doing a lot of research. Our fellow Neil Crittenden presented this poster at AASLD this year. And so we're the first and only group to look at the impact of baseline viral resistance polymorphisms on cure rates post-liver transplant. So Hep C recurs 100% of the time in a liver transplant unless you achieve SVR before liver transplant. And it's basically a death sentence because it will progress to cirrhosis. Half of people will have cirrhosis within 5 years in their new liver, and we and other centers won't retransplant you, particularly if you have renal disease also. That would happen to my mind. I feel like I lost it. So we're now curing it. I think we've cured like 24 out of 26 with these new regimens, and we're looking at impact of baseline resistance polymorphisms. Fascinating thing about Hep C is many people are resistant to these drugs before they even have seen them, which I guess happens in other diseases too. But the fascinating thing is it doesn't seem to matter if you're resistant to the drugs, you get cured anyway. But most of the ones that don't get cured do indeed have these baseline resistance polymorphisms. So what they mean, I don't think anybody knows, but we're working on that, at least in the context of liver transplantation. Dr. Swati Joshi Bharvi in our group is studying the impact of environmental chemicals on hepatitis C progression, and we're a member of the Kentucky Viral Hepatitis Coalition, and we submitted a $6 million grant to CDC to study Hep C and people who inject drugs in Kentucky. Now, unfortunately, the grant was accepted or deemed acceptable by CDC. Unfortunately, it wasn't funded. The funding went to Cincinnati to study the same people we wanted to study, which were in northern Kentucky. And the reason, two reasons Cincinnati got this and not us. So the first reason was that Kentucky doesn't have a needle exchange program. But even if we did, it wouldn't work, because you have to have a new kit for every hit, apparently. But the second reason is at University of Cincinnati, they have a needle exchange van, a little van that drives all over the town, and you bring in your bad needles, and they give you good needles. So that little van was worth $6 million. So I wish we had a van. I want to get a van and load it up with needles and 5% and drive all over the United States. That's not what that's worth. And we participate in industry-sponsored trials. So our hepatologists in our division have participated in this curing of hepatitis C. First with Luis in UK. Luis was PI at UK on the first Pegasus study, or where the registration study anyway. And so we've continued to be involved, and we're still involved. And then I've been involved in an exciting project with Rick Cloud here, who's in the Kent School of Social Work, and he is an expert in adherence. And so we've got a copyrighted hepatitis C adherence technology. It's a smartphone, and it uses your smartphone to help you not use drugs and help you take your Hep C medicine. Because if the concept from the third-party payers is we can't treat everybody, but the one we treat, we want to give extra special care to make sure they get cured. And so they're talking about things about giving cell phones to patients while they're on treatment so they can call and check on them. Rick says that won't work because he says these guys will just sell the cell phones. And then they're thinking about doing home health, sending people to the home, maybe even weekly, maybe more often, which makes some sense from the perspective that when we discharge someone from hospital, we oftentimes will use home health. So do you know that Passport now spends as much on sofosbuvir as they do as all of inpatient care combined? Just think about that. All inpatient health care, combined, they're spending that much on one medication. So from that standpoint, it makes sense. So inpatient care, you have home visits afterwards to make sure they don't get readmitted. So Hep C, it makes sense because it costs just as much to have home visits to make sure they get cured. So we're involved with this in the adherence management realm. So conclusions, so we're talking discovery to cure. One of the only chronic diseases in internal medicine that we cure. We've had breakthrough treatments, but they're expensive. And this is the single largest financial impact to the healthcare system in the history of healthcare. And right now, because of these things, we used to sit and talk about, well, do you use pegylated interferon alpha 1 or 2? Which one are you going to use? It may be 0.5% better in this study, but it's not head-to-head. So we used to bicker back and forth with your favorite drug on which one was better. But now it doesn't matter. Almost everything seems to cure most patients close to 100%. But what is important moving forward for Hep C, and this is a change, is linkage and access to care are the biggest problem. So who are you going to refer to if you diagnose Hep C? There may not be anyone in your area. Once you're referred and we prescribe the medicine, are you going to have access to get that medicine? And so this is why we're opening this new hepatitis C clinic at Jewish Hospital, because we want to focus on linkage and access to care, not just in Louisville, but across the whole state of Kentucky. And these are some of our innovative solutions for unmet needs here in the state. And I wanted to thank a couple people. So Craig and Chris, I'd like to thank them, and Jesse too. So as Craig mentioned, so I have a big NIH research effort, and they've allowed me to pursue these interests in hepatitis C, which is something, outside and beyond that. And so that's one great thing about working at UofL and having these people as my bosses is they give me a lot of flexibility and opportunity to pursue things, especially if I can demonstrate a financial benefit to the system. I'd like to thank Kentucky One and Jewish. These people are very committed to hepatitis C program development through our new clinic. Several collaborators, the Kentucky Viral Hepatitis Coalition, which is led by Kathy Sanders at the State Department of Health, John Zibel at the CDC shared the slides on PWID and drug users. Just in case, so you don't worry about me, I didn't already know all that stuff about Dr. Zibel taught me that and shared those slides, so thanks to him. And my collaborator Rick Cloud on adherence management. So I would encourage anybody in the room that manages chronic disease state to reach out from Rick. He'd love to hear and work with you on adherence management technology for your disease state. Hep C, we can't do it alone. We've got many good mid-level providers. We've got 2 at the VA and one at HCOC, and then another that kind of floats back between HCOC and the VA. So this is a protocol-driven disease state and treatment, so we couldn't do that without them. Hep C coordination is now increasingly important, so just writing the prescriptions when it starts, and then you got 90% of the battle after that. So coordinators are critical for that. Pharmacists like Mary Bishop that work at the AIM clinic really facilitate treatment. And then our clinical trial nurses who have worked with the doctors to facilitate this breakthrough in development of hepatitis C. And I like to thank my research lab, because when I'm out, chasing my Hep C windmills in a Don Quixote-like fashion, Cam Faulkner and people like that are back in the lab doing what I'm actually paid to do and making sure that work gets done. And then our funding agency. So happy to take any questions now. Thank you.
That was outstanding. And when I talk to students, we often talk about the concept of becoming a physician scientist. And sometimes people tell me, well, I'm not sure I want to do that. And when I say, why? The answer is more about, I want to keep up with my clinical skills. And I used to be bothered by that, because I don't know many physician scientists who are not terrific clinicians. And now I can just send them to you to see you at the clinic, because physician scientists really have a perspective where they can pursue not only things in the lab, but also in the clinic, and make them even better at that because they have that larger perspective. So thank you for doing that. I have a couple of questions. One is, if this is so simple to treat and identify, why not push the diagnosis and management of this condition closer to primary care, as opposed to a referral to a specialist, which is important at some stage, but at the early stages, just to get this out there. Number 2, I heard nothing about industry. The main problem here is the cost of these drugs. Only for a CEO to make $250 million of a bonus every year. So how do we tackle the industry? Because you proved to me that insurances can't afford it. So tell me about why not primary care at the early stage of this, and why not tackle industry?
Okay, those are great questions. And I actually wanted to put something from industry perspective on there, but I was worried I wouldn't have enough time, so I'm glad you asked that. So primary care. So there's no reason primary cares can't treat Hep C, because it's easier than diabetes. You don't have to get a finger on blood sugar. But because the costs are so high, and actually in our CDC grant, we wanted to train primary cares to treat, but I think because the costs are so high, the third-party payers are pushing more towards a center of excellence type model for Hep C, and let the specialists, work. A few specialists work closely with the third-party payers to use the medicines responsibly and pick the most appropriate people to treat. But clearly, there's not enough GIs to cure all the Hep C that's out there. And so long term, I don't know what's gonna happen. Screening has to be done by primary care. And so there's PQRS measures that are coming for this type of stuff, but there was CMS actually, I got an email about something they did last week, which I thought was horrible. They said they will only pay for Hep C age-based screening if it's ordered by primary care. Like if you see me for a screening colonoscopy and you're 50 years old, just because you've seen me doesn't mean you have Hep C, I guess. And so the onus is actually on primary care to screen, because it's only going to get covered when you order it, at least for your Medicare and Medicaid patients. Now, secondly, the industry perspective, and this is the argument that they give for their prices, and I'm not defending them, I'm just reporting what they have told me, because I've asked the same questions. And so what has happened over the evolution of Hep C, the first big breakthrough came with telaprevir and boceprevir a couple of years ago. And that was a 48-week regimen that required interferon, ribavirin, and a protease inhibitor. So the protease inhibitor cost about $60,000, and interferon and ribavirin added about another $30,000. So the cost of the entire regimen was $90,000. And so when Gilead launched sofosbuvir, which didn't really, and these other new regimens which don't require interferon, they said, well, wait, you know, this old standard of care cost $90,000, cured 70% of patients and had tremendous side effects. The FDA gave us breakthrough status. You know, we're a breakthrough medicine. We cure 100% of people. We basically have no side effects. Why should we take a discount to the standard of care? Why should we get less than the standard of care? So you can kind of understand their logic. I'm not defending them. I'm just reporting what they're saying. But that's their stance. And then there's a lot of development costs. The sofosbuvir molecule was owned by a company called Pharmacology originally, and Gilead bought that for $12 billion. So they say we have to recoup that cost, but you know, I guess the truth is, even if they never sold the drug, they made their money back on their stock market cap. It just soared. But clearly, what companies have learned is that they can get rich off of liver disease. And so we don't have very many medicines for liver disease in general. And in fact, most medicines they do not take if you have liver disease. But what they've learned is that they can get rich off liver disease. And so we're involved in multiple clinical trials for companies for liver fibrosis, non-alcoholic fatty liver disease, all these diseases that are killing people, and we're watching them die. And so I think this is a direct result of that. So I guess some good things do come, but very controversial area. I don't know the answer.
Yeah, I don't understand their logic. And by the way, I did the calculation. 400 people you're going to cure this year times $90,000 is $32 million, which is still much less than the CEO's salary. Go ahead, sir.
I haven't heard anything about vaccine for a number of years. Has it been decided that it will never work, or is there still effort?
And nobody wants to develop a vaccine when you can make $90,000 a year.
That's wrong.
Questions?
What percentage of, in these asymptomatic people that turn up positive in screening, what percentage of those have abnormal SGOT, SGPT?
Yeah, that's a good question. I don't know, but you guys know?
30%.
How much?
30%.
30%.
30% have a normal liver.
30% will have normal.
30%.
Okay.
One out of three.
Yeah, but you have to be careful because just because they have normal liver enzymes doesn't mean that they have significant hepatitis C. And in fact, most patients that have cirrhosis, from whatever the cause, do have actually lowish liver enzymes, ASTs of 13, 14, 30 maybe. So don't be lulled into a false sense of security. Well, you've got normal liver enzymes. I don't need to worry about this.
Questions?
So on the patients who are injection drug users that we choose to treat and cure, do we have any stats on their recidivism rate? And because I could imagine that some of them would say, well, I got cured the first time,
Right.
I don't need to worry about this, because I don't think we do.
Yeah, so this is why companies don't want to pay for treatment, but we don't know what the rate of reinfection is, and that's why the CDC was funding 2 of these large grants. If you read the fine print, what they wanted to know was actually they're paying $6 million to find what the reinfection rate was, but that's unknown. Now CDC, they're not paying for the medicine, and so they recommend treating all injection drug users, because if you got 5 people that inject drugs, one of them has Hep C, if you cure that one, they don't give it to the other 4. So this is an indication. The more drugs you use, the more you need treatment, but they're not the one paying for the drugs. The companies that are paying for them, the third-party payers say, no, we're not paying if you're using because you just get reinfected. Yep.
Jim?
Let's see, just a back of the envelope calculation of all the incident prevalent patients would be exceed the cost of the Medicare budget. Is there an algorithm for progressive screening and movement of therapy? Since you can't treat everybody, who do you screen? Do you screen everybody?
Yeah, so there's not a national algorithm for that. Now, what the AASLD and IDSA have developed, this was actually the most controversial document they've ever produced, but they do have a Hep C document that kind of starts to address that, and they kind of lump people into highest priority and high priority. And so if you have cirrhosis or MPGN or something like that, you're at the highest priority. And then other things will give you a high priority. But the reason it was controversial is that the third-party payers seized that document and now use that as evidence, saying, well, we're only going to pay if you're at the highest priority. We don't care about you if you're at a high priority. But then you've got these data showing, a 17% all-cause mortality reduction with treatment anyway, and that's not even related to fibrosis. So that's really unknown. I mean, I think we need a national policy. I don't pretend to know the answer to that, but just the finances of it are just mind-boggling.
So it's great to achieve 90 to 100% cure rate now, but is there any evidence that drug-resistant virus is rising or anything?
So most people get cured, but the ones that don't cured have drug-resistant virus. So there's very few that don't get cured if they take their virus. But we have multiple classes, so if you're resistant to one class, you're not resistant to the others. For some classes, the resistance goes away with time. NS5A inhibitors, it seems to persist a long time. Protease inhibitors may persist. Interestingly, the polymerase inhibitor, the sofosbuvir, there's only been a handful of cases of DNA or RNA sequencing confirmed viral resistance ever reported, and that mutant is so unfit, it goes away in days actually after stopping the medicine. And so it's not a problem for that medicine. And in fact, you can actually retreat people with drug that are documented to be resistant to, treat them for longer, add ribavirin and cure them anyway, which I don't understand how you cure them when they're resistant to the drug you're treating them with. That's why I'm not in infectious disease, I guess.
And what about in the case of HIV co-infected patients? Any drug-drug interaction problems?
Yeah, so there's a lot of drug-drug interaction problems, and this is why I love seeing these patients. We can treat and cure almost all of them, but for example, the AbbVie regimen is ritonavir boosted, so some people are on ritonavir boosted Rayataz, so we just hold the ritonavir. That's what we're going to do. But we can still treat them.
When can we expect like a Canadian equivalent or a cheaper alternative on the market?
15 years.
The Canadian equivalent.
I was just wondering about the role for these treatments in treating hepatocellular carcinoma. Have they been studied?
Yes, so they don't improve hepatocellular carcinoma, but Sovaldi or sofosbuvir has an indication for treatment of hepatitis C in patients who are waitlisted for liver transplantation that have hepatocellular carcinoma. So if you have HCC, you get 22 MELD points, at least now that's going to change, and so you can kind of guess to is when they're going to be transplanted. And so you can treat with this medicine not for cure, but to make the virus zero, and so at the time of transplant they won't reinfect their new liver. Now that does nothing for their liver cancer, but there is an indication for liver cancer treatment of Hep C in that situation.
Matt, why do you think the cure rates for people with cirrhosis is less? Is it because of the metabolism of the drug, or is it because of viral liver cell interactions that are?
I think that's unknown, but clearly you're absolutely right. So basically the only thing, we used to have all these negative predictors. If you were a null responder, that was a negative predictor. If you had a high viral load, that was a negative predictor. If you were African American, you're harder to cure. If you have HIV co-infection, you're harder to cure. Basically none of that matters now other than genotype and cirrhosis. And I don't think it's known. Do you guys know why cirrhosis is worse?
I think it's your natural. So these drugs really allow your natural immune system to clear, and cirrhotics are going to have less good immune system.
Okay. Well, thank you, everyone. Have a good day.